underdiagnosis. The rate of ADHD diagnosis has significantly increased over the past 50 years. It is now the most common behavioural problem in children and adolescents, with 6.4 million children and adolescents in the US currently having received a diagnosis. Controversy around this increase questions whether it reflects a real expansion in the disorder or if it is better explained by marketing and drug-fueled motivations as a consequence of growing and ineffective definitional boundaries, as a response to social and cultural processes, or simply an increase in knowledge. One problem is the way in which ADHD is classified. The DSM-4 is a popular diagnostic tool defining ADHD as a behavioural condition characterised by inattentiveness, hyperactivity, and impulsiveness. 6 or more of these symptoms, inattention, hyperactivity, and impulsivity, must have been present in at least 6 months prior to the assessment. This is difficult to determine as the symptoms of the disorder vary across the course of one's lifetime. According to Wylans and Spencer 2010, hyperactivity and impulsivity decays over time. However, inattention symptoms are thought to persist. So we may question whether this 6-month period really is a good, reliable basis for observations of the disorder. Similarly, the observable behavioural symptoms are not sufficient for ADHD to be established as a diagnosis. Svansky and King 1999 note that poor language skills and life circumstances may mediate clinical presentation, so other rating scales may be required to make a better valid diagnosis. ADHD is reported as also being comorbid with multiple other disorders, including depression, anxiety, substance abuse, and learning disabilities. For example, forgetfulness and distractibility are also symptomatic of depression. In fact, Cadisio and Goldberg 2001 estimate 87% of children with ADHD have comorbid disorders, and 67% have at least 2. Considering doctors have to also deal with severe payer and clinical time constraints, complex and comorbid presentations may be overseen. For this reason, many clinicians may make false positive diagnoses of ADHD when another diagnosis may be more appropriate. There are also methodological issues when identifying ADHD in adult patients. Adults assessed through direct interviews show problems in recalling symptoms from childhood. Hence, in such patients, ADHD may actually go underdiagnosed, according to Wylans and Spencer 2010. Many psychologists believe these diagnostic issues have expanded the definition of ADHD, especially under the current DSM-4 criteria. And Woolrich et al. Believe that this may explain the increasing prevalence and potential overdiagnosis. I'll pass it over to my colleagues now.